Okay, welcome everyone to tonight's HAWA talk. My name is Laura Chilcutt. I'm one of the coordinators from the REACH committee within AMSA National. Tonight's talk is by Dr. Malika Fair. She is the Director of Public Health Initiatives with AAMC. She's going to be talking today about health equity related issues in the United States, and then how medical students can help to advance health equity in the United States. Since this is a small group, we'll probably stay a pretty small group. We'll probably just take your questions over the phone, but you can just wait until the end and then we'll go through a question and answer session. The presentation should be probably 20 to 30 minutes. Dr. Fair, if you want to go ahead and start your presentation.
Okay, thanks, Laura, and I appreciate the opportunity to speak for you all today and tell you a little bit about how I got involved in this work and what I think you could think about for your career as a medical student and beyond. So the title of today's presentation is Navigating Your Medical Career Path to Advance Health Equity, and I think it's such a wonderful thing that you guys have this Health Equity Week of Action and you're taking the initiative to think about these issues even as early as your medical school career. So the objectives of today's session is to define health equity and the factors that influence population health outcomes, to discuss the disproportionate burden of disease and shifting U.S. healthcare system, the role of medical students, and your efforts to advance health equity, and then highlight a few opportunities that you can get involved and obtain practical public health, population health related training. So I want to start with this picture on your screen here. The lady wearing the blue dress is a 63-year-old female who has a history of hypertension and diabetes, poorly controlled. Towards the end of her life, she had multiple complications related to hypertension and diabetes and ended up having a below-the-knee amputation, and she later succumbed to her disease due to complications. So this is another picture of her. The gentleman on the right is a 62-year-old who also has a history of hypertension and diabetes, poorly controlled, had a below-the-knee amputation and a foot amputation because of complications with diabetes. And then finally, the last woman is a 54-year-old female who also had complications with hypertension, diabetes, and had a below-the-knee amputation, and she is the mother of a woman in the middle and the sister of the man on the right. So while these stories are probably very familiar to you, seeing African Americans in their 50s and 60s with complications related to poorly controlled hypertension and diabetes and undergoing amputation, this was normal for me. This is my family. So this is my grandmother to the left, my aunt in the middle, and my granduncle to the right. And as a child growing up, I thought that was normal, that most people, when you become an adult and later in life, that you would perhaps lose a limb. And, you know, when I was going through middle school and high school and thinking about what I wanted my career to be like, and I realized that this was actually not normal for a lot of families, and that there were significant health disparities in my community compared to others, and in similar communities that may have had certain social factors or racial, ethnic situations that predispose them to health problems, then I thought, you know, we actually have to do something about this, and I hope that my career can somehow affect these issues. So that's how I got involved. Now, while I told you a story of my family, this is clearly not limited to us. So 40% of African Americans are more likely to die from stroke. 45% of Latina women are more likely to be newly diagnosed with cervical cancer, and 40% more likely to die from cervical cancer. 20% of the nation that lives in rural areas are less likely than those living in more urban areas to receive preventative care and more likely to experience language barriers. And 30% of youth that are LGB, compared to 13% of heterosexual youth, have attempted suicide at some point. Now, these are familiar statistics to all of you if you've had any exposure to health disparities in your medical school training, but something that I think is very disturbing. And you spend a lot of time in medical school and especially on the wards, thinking about giving the best care that you can to your patients and hopefully learning about some of the disparities that we see in delivering quality of care. And as you see on the screen, there are disparities with poor versus high income, Black, white, all minorities listed on the screen, and differences in age as well. So the question then is, what are we trying to achieve here? And as the title of this slide in today's session is about achieving health equity. And it's a state where all people have the same opportunity to attain their full health potential, and no one is disadvantaged because of social position or circumstance, and this definition comes from the CDC. Now, as a medical student and as someone who wants to become a physician, some of these issues are not always at the forefront because it's stressful when you're thinking about the next exam and you're thinking about how you're going to learn all there is to know about taking care of a patient and not making a mistake and trying to do well on the boards and match into the best residency you can. Thinking about comparing the patient that you're taking care of with the population problems that we have in the U.S. is a little bit daunting, especially considering that what you're studying in school about the biologic and the genetic factors that relate to health, that's only one part of the picture. So if you look at this diagram on the screen, it shows what other things influence health besides just the biologic and genetic factors. And there's several studies that say that health is related to over 80% of other health problems. And I'm hearing a little bit of an echo, so I don't know if everyone else is on mute or not. So looking at this slide here, you see that the physical environment, your educational background, your gender, your employment, your financial, social status, your social environment, all that can impact your health. And these are called social determinants of health, and I know you've heard of this before, and the official definition is the conditions in which people are born, grow up, live, work, and age. Now, what's daunting, I think, about this slide is when you are spending all your time taking care of patients and trying to think of your differential diagnosis and going through all the things that you have to think about, it's hard to then take the time to think about all these other factors. What medicines can your patient afford? What's their living environment? Do they have the social support to deal with the bad news that you're about to deliver to them? So we're trying to think about it in terms of the levers that you can affect even as a student. And as you see on the slide here, and sorry for some errors there in that slide, so the first one is policy making. There are several physicians who are actively engaged in taking the stories from their patients and from their experiences and applying it on a local, state, and national level. So the level of involvement that you may be interested in is totally up to you, but your experiences with patients can greatly influence the policies that could affect people's health across the country. And this is something that is very much open to students, residents, practicing physicians, and there is a paucity of physician involvement on the Hill. I spent a rotation in residency here in D.C. during the time that healthcare reform was very much underway, and I was surprised to see that there were very few physicians in many of the sessions that I was sitting in. And we were talking about things that we think about all the time, every day. And I didn't mention this at the beginning, but I am an emergency medicine physician and assistant clinical professor at George Washington University, and I'm still practicing as well as working here at AAMC. So I never forget what it's like to take those patient stories and then to do something about it. So if that's something that you're interested in, I would definitely encourage you to think about that. The social factors is, we often say, for those of us who are not primary care physicians, that somebody else will have to deal with that, because I may not have the time in my 10-minute visit or my 5-minute visit to deal with everything else that could affect that person's health. And I think in some ways that is definitely the case, but as physicians, we have to know that we can work with other partners who can meet those needs. So whether that's the social worker or it's working with programs like Health Leads you may be familiar with, that you can write a prescription for something that is a social determinant of health, food, housing, things like that, and they will help meet that need for the patient. Whether it's working with a medical legal partnership and having a lawyer on site who can deal with some of the legal issues that may affect, for instance, excess of mold in an apartment building that could be contributing to an asthma exacerbation. Or just even incorporating social factors into our electronic medical records, into our review of systems, and see how we can work on an with an interprofessional team to address some of these. Now, health services is something we all think about in terms of making sure that there's access to care. But what you'll find as you progress, and maybe those of you on this call who are very much interested in improving health equity, is that the longer you're in this, when you go into residency and you're going into practice, there'll be several pressures upon you that may not encourage you to provide more health services than not, with reimbursement, with wanting to practice in an area that may not be underserved, and dealing with insurance issues like taking Medicare and taking Medicaid. But those decisions that you make as a physician influence the health services that are available to the patients that you are very interested in serving. And then finally, individual behavior. So at first, when I got into this and I was thinking about improving health disparities, I thought that my career would be focused on helping people live healthier lives and talking in churches or religious organizations and doing a lot of health behavior and health education work. And this is extremely important, and I think we can never underestimate the voice that you have as a student, as a resident, as a practicing physician in terms of influencing a patient's individual behavior to make healthy decisions. I personally think that this is something that we often de-emphasize because we don't always see the results immediately, but I think it's something that it's never too early to start doing that and to incorporate that somehow into your career. So in terms of the healthcare landscape, I briefly mentioned this in terms of things that you may have to address when you are out and practicing, but you may or may not be aware that there is an increasingly more diverse U.S. population. In the 2010 census, it was the first time that children born that year under the age of 1 were majority minority, the babies born that year. And in 2050, our country will be majority minority. So given this increasingly diverse patient population, we have to create a workforce that is culturally competent and prepared to meet the needs of that population. And focusing on these issues related to health equity is a way that we can get there. You know that we have increasing growth rates in healthcare spending, although it's starting to plateau a bit, but it's much higher than it was several years ago. And fortunately, we have the expansions with the Affordable Care Act, which will provide more insurance coverage and more investments in preventative care and collaboration between various health providers. But it's not going to solve all of our problems, and many will argue that there may be some even less access to care for certain populations because the number of physicians hasn't really changed. So for you all in your medical schools, hopefully you are experiencing the shift that I was experiencing in medical school and that we can see across the country as curriculum is becoming, it's adapting with the times. We used to think of the specialty or the physicians in general as expert-centered, individualistic, focused on just the basic or clinical science, the pathophysiology, the individual patient, and maybe caught up in the status or your title, paternalistic. And we really can't think of our practice that way anymore. We have to adapt to the technology that we have. We have to be patient-centered, appreciate the diversity of perspectives and individuals that we can work with. We have to work with other professions as a team member and not always expect to be the decision maker or even the leader of the team sometimes. We have to actively translate the research that's being done from bench to the bedside. Many of you are familiar with the competency-based education that we are moving towards, and making sure that when you graduate from medical school and you finish residency, that you are a competent and proficient physician to practice independently. And we're focusing more on making huge breakthroughs within medicine that can impact a large part of the population. And this interest in health equity sits right there. So how do we do this? This is, our thoughts when you've got this significant healthcare expansion and a new push from the media, from the federal government on making sure that we have a population health focus, then we have to supplement our medical training. Now, this is already happening with medical schools across the country that are including population health and public health within their curriculum, and some are doing it in different ways than others. But as medical students, you will have to be responsible for supplementing your own training based on your interest and where you see your career. So I have a few ideas in terms of the role of a medical student and the things that you should be thinking about right now if you have this interest. So at first, I would think about where you are in school and where are the needs of your local community. And are there specific pockets of poverty or pockets of health disparities that are close by to you? Now, this may be extremely obvious by driving down the street or maybe even right outside the doors of your medical school. But if you're not sure and you're associated with a hospital that's not-for-profit hospital, you may be aware that all the not-for-profit hospitals have a new requirement to do a community health needs assessment. And so I would look into that. It should be posted online and figure out for the community that the hospital is serving, what are the top needs in that community? And if you and your friends and colleagues are thinking about starting a new group at the medical school or doing a community service activity, I would make sure that your activities line up with the needs that you've identified with that, on that community health needs assessment. You may also find online, or you could contact your hospital to see what their implementation strategy is. They may have, if the top need is reducing obesity, they may have a hospital-wide program to do that with their patients. It would be great if the medical students could get on board with that and see in what way can students help talk to their patients about losing weight, or maybe even institute a fitness program. I think it's extremely important not only to be passionate and fueled by what you want to accomplish, but to be data-driven and to realize what the needs are in your community and align your efforts with those needs. I've mentioned this briefly about the change in the demographics of our population, but this idea of providing culturally competent care is something that's really interesting because you don't necessarily have to be of a particular race and ethnicity to be culturally competent, and sometimes you may not even be culturally competent just because you have that same affinity. But I think what's most important here is the time and the investment that you place in getting to know the community that you're going to be serving, and your adaptability, your ability to create trust between your patients and yourself. And to do this, you have to make sure that you are placing yourself in those rotations that will allow you to have maximum exposure to underserved communities. You may be interested in picking up a second language if you find that your patient population primarily speaks English as a second or third language. There may be courses that you want to take both as an elective or even outside of medical school that will enhance your ability to provide excellent care when you finish residency or even during residency. And I mentioned this as well about policy change. I think that medical students sometimes want to wait until they're a practicing physician to get involved, but I think now is the time to at least become aware of some of the issues that physicians are facing today. On a basic level, this will help when you're going into residency and you're interviewing and you understand some of the pressures that your colleagues and your attendings are under. But if you have a specific specialty that you're interested in, or even within AMSA, I would get to know what are the top advocacy issues for your field, and what are people talking about, what are physicians worried about, and as a student, how do you feel about that? Should you be talking to your representative or your senator? Should you be writing letters? Can you do a Capitol Hill Day within your state, or come here to Washington, D.C.? These are all things that are available to students, and you'd be surprised by how receptive people are to your stories, because you are seeing patients and you do have an insight into our healthcare system. And then finally, becoming a leader in health promotion and health education, and understanding who your audience is, whether it's your family members, your friends who are not in medical school, your volunteer group, your religious organization. You are now almost an expert, and people will take what you have to say seriously. And in terms of influencing individual behaviors, if you don't speak up, who else will? So I've mentioned a few things that you can at least get involved in, specifically if you are starting from the beginning and you want to have a career that has a lot to do with health equity. I think the first thing you should do is find a mentor. It doesn't have to be a mentor in your specialty. They don't even have to be a mentor in your medical school, but they should be a mentor that is working on something that you are interested in. A lot of people will respond to an email that says, I've read your research. I think that you're doing something that I might be interested in the future. Do you think I can just talk to you for a while? And you would be surprised the type of connections that you can make with mentors across the country. So I would urge you to reach out and do that. Some of you may be interested in pursuing a joint degree program or a certificate program. You know, I may get a question today about should you get, a master's in public health or a PhD. It depends on what you're interested in. I did get a master's in public health in medical school, and I thought it was extremely helpful to give me the background that I needed and the tools that I needed early on in my career so I could help plan what type of residency I wanted to go into and where did I want to eventually practice. But it's not necessary. There are plenty of fellowships and electives and experiences that can give you an exposure to this work. You may at your institution have a track program, like a health policy track or public health track, community health, global health. I would encourage you to get involved in those. This may be the last time that you actually have time on your hands. It may be surprising that medical school, you have more time than you will in residency. And so the things that you may not be able to focus on in residency, now would be that time to do that. That includes elective rotations on the things that you're really passionate about. I mentioned joining your professional society sections. That's something that you're probably doing anyway in terms of preparation for applying to residency. But I think it's more important to understand how your specialty thinks, what are the concerns, and if you're specifically interested in health equity in your specialty, what are the main disparities and how is your specialty dealing with the healthcare disparities and the health disparities related to that. Interest groups, now that's something that you can develop within your institution. Clearly all of you guys are involved in AMSA, and hopefully your institution, your school chapter is dealing with these issues. But if not, you should open it up and see if there's other students who are equally as passionate. And finally, I would urge you to explore electives that you wouldn't even be thinking about. That first summer between first and second year, during your fourth year, some of you are able to take electives during your third year, or maybe even take a year off of medical school. We have developed a new website that just came out a few weeks ago called Public Health Pathways, and this provides training opportunities for pre-medical students, med students, residents, and post-residency. And this includes paid internships, unpaid, all across the country and across the globe. And you can search based on things that you're interested in. If there are things on here, opportunities that are on here that you are interested in and you have questions, feel free to contact us. And if you see something that is not on here that you know about, we also want to hear about it, because we do want this to be a resource for students who are interested in enhancing their career. And frankly, medical school, the training is short, and there's a lot that has to be fit in. And every medical student that goes through is going to want a slightly different experience. So this is a resource that you can make sure that your electives and your the time that you have in medical school and after medical school is worthwhile for you. Other resources we have at AAMC are careers in medicine. We have a section on, if you're interested in a public health or a service section, there's information on the website. If you're interested in doing a dual degree with an MPH, we have that list as well on the Pathways site that I just mentioned. And then finally, with MedEd Portal, you may be familiar with that, but that's our online library of curricular resources that faculty have posted from all across the country and even across the world. And if you want to start a course or start a track at your medical school and you find something on there that's particularly interesting, then you can download it, you can contact the faculty members, and you can try to get that instituted at your medical school. I find that the students don't realize how much power they have in terms of influencing the curriculum at their school, and a lot of the great ideas and innovations that we hear about here at AAMC were started by students. So this is a place that a lot of student ideas have been birthed into innovative curricular opportunities. So I'm going to stop here. You see that there's my phone and my email address if anyone wants to discuss anything further, and I'll open it up for questions. I appreciate you listening to this brief talk about how you can enhance health equity using your medical career, and I'm opening up for any questions.
Dr. Fair, I've got a question. You mentioned ways that doctors can already on their own, in their own practice, begin expanding resources for underserved populations. And you give a suggestion of kind of things like taking Medicaid and Medicare and addressing social factors and things within the office. Do you have any suggestions for someone who's in private practice who wants to make sure that those populations know that you are open to working with them and that you're like a welcoming office, basically, for whatever your specialty happens to be?
So I think that's a great question. You know, I have been in different cities and where there are a lot of primary care physicians or a lot of physicians who are in private practice. And, you know, I've talked to community members and I said, so, you know, where do you go and get care? And they told me they went to, you know, the complete other side of the city. And I asked why, and they said, oh, because I feel welcomed there. And so I said, you know, you drive 25 minutes away just to go to a particular hospital or see a particular doctor, and you know, the person who I was talking to was a cab driver, and he said, oh yeah, they treat me really well there. So, you know, how do you do that? How do you make sure that the community knows that you are open to that service? Well, I think it definitely takes outreach. So, you know, it takes maybe showing up at community events and maybe joining a community advisory board and making it known that you're open and honest and willing to take care of a patient population if there's some sort of barrier in terms of them realizing that they can come to you. I mean, accepting Medicaid is probably the best way to start because so many of our patients, especially now, are going to have Medicaid as their primary insurance, and that's a barrier. Also, having flexible hours. I mean, it's hard to say you maybe want to consider working nights or weekends, but having alternate hours to give people better access is something to think about because a lot of people are in these jobs they can't just take off in the middle of the day or there's limited transportation, and so making sure that we are flexible. I mean, I'm an emergency physician, so we're open all the time, but we often are doing primary care-related work, and that's not necessarily our preferred function or even probably the best function. We take care of anyone and everyone who comes in our doors, but we understand that having a regular primary care physician and having that continuity of care is really great for patients, and it helps us do our job when they do have that access outside. Any other questions, or feel free to type your questions as well if you'd like to.
The chart that you had on there for the public health pathways, is that an AAMC page?
Yes.
Is that where that link is from?
Yes.
Okay.
If you just go to the AAMC main page and just type in public health pathways, you'll find it there.
Okay.
And for those of you who are on, I can go back to the slide here and you'll see the web link as well. And so I gave my contact information. I'll put the slide up again, but if there are any other questions or if you want to just find out more about opportunities or ways that you can incorporate health equity into your medical school, your process along your continuum, I'm happy to discuss further.
Does anyone else have any more questions? All right, looks like that's about it. Well, thank you very much. It was a very informative talk.
Well, thank you for allowing me to speak, and I look forward to hearing from any of you who'd like to reach out. Have a great day.
Right. Thank you. And for those of you who are still here, anyone who's interested in seeing the PowerPoint, we will have the PowerPoint up with the recording later on the AMSA webpage. Thanks for attending tonight's HAWA talk, and have a good evening.